Welcome back to Surgery Smart, Cut to the Core podcast, where we break down essential surgical topics to help you understand surgical conditions. I am your host, Major Munish Chauhan, and I am a General Surgery Registrar in the British Army and at Oxford Deanery. I am also a Senior Research Fellow at the Centre for Army Leadership with a focus on transformational coaching for self-leadership, resilience, and metacognition. If you find these topics valuable, feel free to connect with me on LinkedIn to discuss them further. In today's episode, we are diving into Gastro-Oesophageal Reflux Disease or GORD. This is a condition that not only a frequent topic in the exams, but also a significant clinical issue affecting millions around the world. We will explore the key aspects of GORD from understanding its underlying mechanism and recognizing its varied presentation. Here is a snapshot of what we will discuss in the episode today. Starting with the pathophysiology, we will uncover the role of the lower esophageal sphincter and its dysfunction. We will also talk about the hiatal hernia in GORD development. I will refer to the lower esophageal sphincter as LES for the rest of the episode. Clinical presentation, we will discuss classic symptoms such as heartburn and regurgitation. We will also touch on the less obvious signs such as chronic cough and hoarseness. In the next episode, we will talk about the diagnostic approach and the management of GORD. So let's start by breaking down the pathophysiology of GORD, the lower esophageal sphincter and its dysfunction. GORD often stems from the dysfunction at the LES. The LES is a critical barrier that prevents stomach content from moving up into the esophagus. The LES is a band of smooth muscle located where the esophagus meets the stomach. Under normal circumstances, it maintains a high pressure to keep gastric acids and food from refluxing into the esophagus. However, when the LES malfunctions, this barrier weakens and reflux becomes a problem. The most common issue is transient LES relaxation, which is a brief, inappropriate relaxation of the sphincter that occurs even without swallowing. These episodes allow gastric content, including acid, to escape into the esophagus. Another factor contributing to LES dysfunction is reduced basal LES pressure, which can result from factors like obesity, smoking, and the use of certain medications, such as the calcium channel blockers. In these cases, the LES tone is compromised, further facilitating reflux. Post-meal periods also exacerbate the issue. After eating, the LES naturally relaxes, which allows the food to pass into the stomach. However, in individuals predisposed to reflux, this relaxation can linger around for longer, especially if they lie down shortly after the meals. This contributes to the acid exposure into the esophagus. This dysfunction underscores why simple lifestyle changes, such as avoiding large meals before bed or elevating the head of the bed, can significantly reduce symptoms of GORD and also prevent more serious complications over time. Let's move on to the hiatal hernia and its role in GORD. A hiatal hernia occurs when the part of stomach pushes through the diaphragm's esophageal hiatus. The hiatus is a gap in the diaphragm muscle that separates the chest cavity from the abdominal cavity. This anatomical change can compromise the protective barrier between the stomach and the esophagus, contributing to GORD. While not every individual with a hiatal hernia will develop reflux, the condition is a well-established risk factor. There are two main types of hiatal hernias: the sliding hernia, which is the most common, and the paraesophageal hernia. In a sliding hernia, the gastro-esophageal junction slides above the diaphragm, disrupting the angle of Hess. The angle of Hess is critical for preventing reflux. In contrast to the paraesophageal hernia, where a part of the stomach herniates next to the esophagus, while the gastro-esophageal junction remains in place. Although this is rare, but this type of hernia can lead to more severe complications, like strangulation, requiring urgent surgical interventions. From a pathophysiological standpoint, the diaphragm and LES work together to form a barrier against reflux. A hiatal hernia interferes with this coordination, weakening the LES function and increasing the likelihood of gastric content entering into the esophagus. In addition, hernias can lead to delayed gastric emptying, further increasing the intra-abdominal pressure and promoting the reflux. For many patients, hiatal hernias remain asymptomatic, but when GORD symptoms become unmanageable or complications arise, surgical correction may be necessary to prevent ongoing damage. Now let's talk about the acid reflux and mucosal injury. Acid reflux is the hallmark of GORD, and it's the direct cause of mucosal injury in the esophagus. When gastric acid, such as pepsin and the bile acids, are refluxed into the esophagus, they irritate the esophageal lining, leading to inflammation, and over time, it damages the lining. This chemical irritation results in esophagitis, which simply means the inflammation of the esophageal mucosa. Prolonged acid exposure can lead to Barrett's esophagus, a serious complication where normal esophageal squamous epithelium is replaced by columnar epithelium. This condition significantly increases the risk of esophageal adenocarcinoma, which is a key concern for those who have chronic GORD. Several factors can exacerbate the mucosal injury. For instance, gastric hypersecretion, such as that seen in the Zollinger-Ellison syndrome. This can increase the volume of acid in the stomach, making reflux episodes more severe. In addition, impaired esophageal clearance, which can result from the poor esophageal motility or reduced salivation production, can also hinder the esophagus's ability to neutralize the acid, which leaves it exposed to damage for longer periods. Conditions like gastroparesis, which delay gastric emptying, also increase the risk of acid reflux by prolonging gastric content retention and raising intra-abdominal pressure. To manage acid reflux and prevent mucosal injury, treatments like PPIs, proton pump inhibitors, are commonly prescribed to reduce gastric acid production. Along with this, lifestyle changes are also important to mitigate the reflux episodes and protect the esophagus from further harm. Let's talk about the role of obesity and intra-abdominal pressure. Obesity is a well-established risk factor for GORD. It's mainly due to the increased intra-abdominal pressure. Excessive fat, especially around the abdomen, pushes against the stomach and can cause gastric content to be forced into the esophagus. The increased pressure on the stomach can overwhelm the LES, allowing acids to escape into the esophagus. Moreover, abdominal fat can directly impair LES function. Fat deposits around the stomach and esophagus can exert mechanical pressure on the LES, leading to its dysfunction. This can contribute to more frequent reflux episodes. Obesity also impacts diaphragm mechanism, limiting its ability to support the LES and contribute to effective reflux prevention. For patients struggling with obesity, weight loss is often an essential part of managing GORD. Reducing intra-abdominal pressure through weight management can significantly reduce reflux symptoms and improve the effectiveness of the LES. In more severe cases, bariatric surgery can offer long-term relief by promoting significant weight loss and alleviating the pressure on the stomach and esophagus. As a result, it improves the GORD symptoms. Let's move on to the complications of GORD pathophysiology. When the mechanism of GORD persists over time, they can lead to a range of complications that impact not only the esophagus but also the other parts of the body. These complications arise as a result of prolonged acid reflux, ongoing irritation, and body's attempt to heal itself. One of the most common complications is erosive esophagitis. Chronic exposure to gastric acid can cause inflammation of the esophageal lining, leading to ulcers and erosions. This ulceration can be quite painful, and in severe cases, it may cause bleeding or strictures. Strictures happen due to the scar tissue that forms during the healing process. Erosive esophagitis can be detected through endoscopy, and it typically requires aggressive acid suppression therapy to prevent further damage. A more serious and long-term complication is a Barrett's esophagus. This condition occurs when the normal squamous epithelium cells lining the esophagus are replaced by columnar epithelium. This happens as a result of the repeated injury from the acid reflux. Barrett's esophagus is considered a precancerous condition as it significantly increases the risk of developing esophageal adenocarcinoma. Surveillance through regular endoscopic screening is vital for patients diagnosed with Barrett's esophagus to detect any signs of malignancy early on. Another complication of chronic GORD is the formation of strictures. Persistent inflammation can lead to development of fibrous tissue in the esophagus, which narrows the esophageal lumen and can make swallowing difficult. This condition, known as dysphagia, can significantly affect the patient's quality of life. It makes it difficult for them to eat or drink without pain or discomfort. Strictures are often treated with dilatation procedures, although they may recur and require repeated interventions. In addition to these esophageal complications, GORD can also result in a range of extraesophageal manifestations. These include symptoms like chronic cough, laryngitis, and asthma-like symptoms. These occur due to microaspiration of gastric acid into the airway, leading to irritation of the larynx, bronchi, and lungs. This is often referred to as extraesophageal reflux, and it can be particularly challenging to diagnose as the symptoms often mimic other respiratory conditions. Treating the underlying GORD can help alleviate these symptoms, but in some cases, patients may require additional management for respiratory issues. Together, these complications highlight the importance of early diagnosis and effective management of GORD to prevent long-term consequences. By addressing the underlying mechanism and providing appropriate treatment, we can reduce the risk of developing these severe complications and improve patient overall health and quality of life. Let's move on to the clinical presentation of GORD. The clinical presentation of GORD is varied, and recognizing the hallmark symptoms is essential for timely diagnosis and treatment. While some symptoms are quite specific, others can be more subtle and atypical, which can complicate the diagnosis. Today, we'll explore the common symptoms, atypical presentations, and some important red flag symptoms. Let's start with the common symptoms. The most common and pathognomic feature of GORD are heartburn and acid regurgitation. Heartburn is a burning sensation in the chest, usually just behind the breastbone, which often occurs after eating or when lying down. This is caused by the acidic gastric content refluxing into the esophagus and irritating the esophageal lining. The pain typically worsens when certain triggers like spicy food, large meals, or alcohol. Acid regurgitation, on the other hand, involves the sensation of acid and food coming back up into the mouth, which can lead to a sour or bitter taste. This symptom can often be mistaken for indigestion or reflux, but it is distinct in that individuals can feel the actual movement of stomach content into the esophagus. These two symptoms, heartburn and acid regurgitation, are the hallmark of GORD. These are what most patients report when they seek help. They are so characteristic that they are often used as the diagnostic criteria for this condition. Let's move on to the atypical symptoms. Diagnosing GORD isn't always straightforward. In some patients, the condition presents with atypical symptoms that are often overlooked and misdiagnosed. For example, chronic cough is a common yet unappreciated symptom of GORD. The cough occurs due to microaspiration of gastric acid into the airway or irritation of the vagus nerve from acid exposure. These patients often present with a persistent cough that doesn't respond to typical treatment for respiratory issues like antibiotics or inhalers. Another atypical symptom is hoarseness or sore throat, which can result from acid irritating the vocal cords. In some cases, individuals with GORD may even report asthma-like symptoms, such as wheezing or shortness of breath, especially at night. This is because the acid reflux can irritate the airways and mimic symptoms of asthma, making it difficult to distinguish between the two conditions. In fact, many patients with GORD who also have asthma may find that their symptoms worsen during the reflux episodes. Recognizing these non-classical presentations is crucial for correct diagnosis. If a patient has unexplained respiratory symptoms or a persistent cough, it's important to consider GORD as a potential underlying cause. This is particularly important if traditional treatments for respiratory conditions are not effective. These atypical presentations highlight the complexity of GORD and the need for broad diagnostic approach. Let's talk about some of the red flag symptoms. While most cases of GORD can be managed effectively with medication and lifestyle changes, there are some red flags that should raise concerns. These red flags may indicate more severe complications or even underlying malignancy. They require urgent evaluation. One of the most concerning symptoms is dysphagia and difficulty swallowing. This could be a sign of esophageal narrowing or stricture, which can occur due to chronic inflammation from acid reflux. Strictures develop as a result of scar tissue formation, leading to the esophagus becoming progressively narrow, making it difficult for patients to swallow. A new onset of dysphagia warrants further investigation, as it could indicate complications of GORD, and in rare cases, it may be a malignancy. Another concerning symptom is unexplained weight loss. This could be a sign that the patient is unable to eat enough due to the pain or difficulty swallowing. Persistent weight loss should also always prompt consideration for esophageal cancer, particularly in patients with a history of GORD or Barrett's esophagus. Another red flag symptom is hematemesis, the vomiting of blood. While this is a less common complication, it may occur in severe cases of GORD if the esophagus becomes severely inflamed and ulcerated. Blood may appear as bright red or as coffee ground material if it has been partially digested. Hematemesis could indicate significant damage to the esophagus, such as esophageal ulcers or varices, and it will require immediate medical attention. So in summary, recognizing the wide range of symptoms associated with GORD is essential for effective diagnosis and treatment. While heartburn and acid regurgitation are the hallmark symptoms, atypical presentations such as chronic cough, hoarseness, and asthma-like symptoms should also be considered, especially when the patient's history and traditional treatment does not fit the picture. Additionally, red flags like dysphagia, unexplained weight loss, hematemesis should never be ignored, as they could indicate more serious complications or malignancy. By recognizing these symptoms early, we can prevent long-term damage and help manage GORD effectively. Thank you for listening to this episode. In the next episode, we will talk about the diagnostic approach to GORD, including endoscopy, pH monitoring, and manometry. Then we will build up on that and talk about management of the GORD, including the medical management and surgical management. Until then, keep learning, stay sharp. Thank you for listening to Surgery Smart. Thank you for listening to Surgery Smart Cut to the Core podcast.